Kajala Medical presents COVID-19 The Answers, the show that delivers the scientific, evidence-based knowledge that can safely return us all to our pre-COVID lives. My name is Dr. Fumi Okunola, and I'll be hosting the show. Every week, you can listen to me interview a highly respected professional about the science that can reduce your risk of becoming infected with this coronavirus. Hello and welcome to COVID-19 The Answers, Episode 8, Part 2, Accounts of Rapid Testing in the Field. Today I'd like to introduce you all to Professor David Harris, PhD. Professor Harris is the Executive Director of the University of Arizona Biorepository, a Professor of Immunobiology, Medicine, and of the B105 Institute at the University of Arizona in the USA. Professor Harris is a graduate of Wake Forest University in Winston-Salem, North Carolina, where he obtained a Bachelor of Science degree, cum laude, in biology, mathematics, and psychology in 1978. He earned a Master's of Medical Sciences, summa cum laude, from Bauman Gray Medical School in 1980, and his doctorate in microbiology and immunology, magna cum laude, from Bauman Gray Medical School in 1982. Professor Harris's research interests include stem cells and regenerative medicine, cancer research, and stem cell transplantation and gene therapy. He established the first cord blood bank in the USA in 1992. Welcome.
Thank you very much for inviting me.
David, out of interest and for the audience, could you please explain what a biorepository is and what is the B105 Institute?
Sure. A biorepository is a large collection of biospecimens like blood, sera, plasma, biopsies, tissue. In our particular instance, it's all clinical related, so we don't do animals or plants or only from patients. In our particular instance, it's clinically annotated biospecimens so that we have the electronic health records that go along with the specimens so we can look longitudinally to see what has gone on in terms of patient diagnosis, patient treatment, patient response, and correlate that with the biospecimens that we have in our facility. And essentially the facility is a large collection of freezers and liquid nitrogen dewars and other types of apparatus for storing those samples in an organized fashion so that we can provide them to individuals who are interested in research, as well as provide them with de-identified data that goes along with those particular samples. Now, the Bio5 Institute is sort of a consortium, a cross-disciplinary consortium of investigators at the university that goes through 5 different disciplines, which is clinical, plant, animal, research, and some others, molecular biology. And they're sort of placed in one large building, so they have an opportunity to run into each other and then potentially talk about collaborations and facilitate the type of interactions that would normally come in a departmentally based setting.
Oh, so that's, fantastic and pioneering research going on there. Thank you for sharing that. Okay, so let's continue.
Sure.
So, we've talked about rapid testing with Dr. Michael Minner. Today, I want to share an example of how a program of mass testing worked in a real-life situation. Between the fall of 2020 and April 2021, using a test, trace, and treat strategy under the leadership of Professor David Harris, the University of Arizona went from 4% of people on campus testing positive for COVID-19 to less than 0.5%. This corresponds to 4,172 people testing positive in August 2020 to 4 people in March 2021. The university began the pandemic with 45,000 students and 20,000 staff working online to resumption of in-person classes with 100 people in attendance per classroom within 7 months. This was a remarkable achievement because if you can remember, the COVID vaccines did not become available until December 2020, and a lot of national and international universities remained closed to in-person classes for up to a year or longer. On March the 11th, 2020, the World Health Organization declared the novel coronavirus COVID-19 outbreak a global pandemic. So, David, could you please tell the audience what happened at the University of Arizona after that announcement and what you and your colleagues decided to do?
Right. It actually seems such a long time ago now. When you talk about 4%, actually there was a time when it was above 11% positivity at the beginning, and then dropped down below 1%. But I can remember that March of 2020, when the results were coming back from the rapid spread of the infection, the health consequences, the astounding number of deaths that were occurring. We didn't really have any antivirals. We didn't have any real treatments, didn't have a vaccine. So we, like everybody else, was trying to decide what to do. And the university stepped in and decided to go to remote learning. You didn't want to shut the university, but you actually couldn't take the chance of doing teaching in person. So everything went to remote learning. We at the biorepository were asked to come up with testing kits to be able to test the campus community. So we spent a lot of time in the early days constructing PCR kits, collection kits, going out and collecting samples and looking at prevalence of the virus in the community. And that was the point where we decided that was not going to be an easy way to mitigate the infection, because it simply took too long to get results back. And so we then spent a lot of time trying to decide what kind of rapid test we could develop or could implement to be able to get results back quickly. Because obviously, I don't think people realize that, if you have no students, you have no money. If you have no money, you have no university, regardless of how many good people you have at the university. And so if you send everybody home, and they're not paying for books or for rent or for their classes, essentially your universities can go bankrupt very quickly. And we're talking tens to hundreds of millions of dollars per university that they're losing. And so we were trying to implement as much as possible a way to get classes open in some respect. And that's where we came up with this test and treat plan to be able to slowly reintegrate the community back so that we could have people on campus, individuals who were working in laboratories would be able to come back. NIH grants would continue to go forward, but in a safe manner, to be able to protect those individuals who would be most likely to come in contact with the virus. That unfortunately was my group at the beginning. When we say unfortunately, because we didn't really know how serious that was going to be. And so from March until today, we've been at the university doing that sort of work.
Fantastic. So, so in the fall of 2020, well, I thought it was 4%. You're saying actually 10%.
Actually, it was over 11% at one point.
Wow.
There was a couple of weeks, when the kids were coming back, that it got up over 11%. It mirrored the surrounding community. 90% of the students live off campus inside of the city's community, so you expect their incidents to be very similar. And it was at the beginning, until we could go in and test and trace and emphasize to people, how to take the precautions to prevent spread of the virus.
So, I mean, over 11% out of a population of 65,000.
Right.
So at that time, SARS-CoV-2 had an R naught of 2 to 3. So every one person infected would go on to infect another 2 to 3 people. Could you please give us some idea how quickly things would have got out of control without your test, trace, treat strategy?
Well, that was what we realized at the beginning. We brought together epidemiologists, public health specialists, the former Surgeon General of the United States, as well as the researchers on campus, to try to determine the best approach to try to mitigate. It really simply wasn't enough to be able just to measure prevalence, because the R0 was so high that by the time you knew who was infected or not, they'd already infected other individuals. And so the idea was, how could we implement a testing strategy where we could get results back, within an hour or so that an individual could come in, they could be tested, and they could be held sort of in isolation until the test results came back, within the hour, and then you could then let them go at that point. So we looked around at that point because we needed to replace the PCR results, which generally would take 24 to 48 hours to get results back. Even though you could upscale it to be able to do thousands a day, it was just that lag time to be able to get results back. And when you talk about 20-year-olds, that's a long time. So, they don't want to be kept in isolation for 24 to 48 hours. So we looked at the rapid tests that were coming out at the time. We evaluated various manufacturers. We went out and purchased tests to be able to do our own in-house validation. And we settled upon the Quidel rapid antigen test. We liked it for a variety of reasons. You could get results within 15 minutes. But more importantly, it was designed to scale up so that we could do the thousands of tests a day that we needed to. It was connected to the web so that we could upload data into patient records. So, their test results would be in their electronic health record. And we could download the data into our own databases to be able to follow the course of the infection and see how infected individuals were. So we decided on that. That was a strategy we set up during that first summer. So when you think about it, of that first spring semester, everybody was still sort of fumbling through it, trying to do the best we could. It wasn't until we got into the summer that we could take the strategy that I talked about. We first implemented it with the athletic teams that were at the university, the football team, the basketball team, sort of on a small scale. We're only dealing with hundreds of people. How would that work? How many days a week did you have to test? How quickly did you have to get test results back? So that when the kids came back in the fall of that year, we were set up to be able to test thousands a day. And so we decided on the strategy of test everybody as they came back to campus, get the results back to them. So we were testing 2,000 to 3,000 a day. Get results back to them immediately. Those that were infected immediately pull out in quarantine. Those that weren't, you were allowed to go to their dorm, come back to class, come into a research lab, and then implement a strategy where, okay, you're not infected today, but what about tomorrow? And so it was the strategy of testing once a week going forward to be able to catch those individuals who previously were naive and now had become infected before it could get out of control. And part of that had to do with tracing, so that if we knew that you were positive, we don't know who you talked with the last couple of days. And so through a de-identified smartphone app, we could tell when your smartphone got close to another smartphone, although we didn't know who owned the smartphones, but we could tell the other smartphone that you just were around an infected person and you should get tested. And that allowed us to trace those individuals and encourage them to take steps to protect their own health. And then we followed that up by doing wastewater testing of the individual dormitories and congregate settings where it was not really feasible to go in and do that every day, but at least to give us sort of an idea of, is there virus present in the building and how much virus? And then we could go in and target those areas, like the 5th floor of the dormitory or the cafeteria, clean that out, test all those individuals, and then re-educate them as to best ways to prevent infection. So it was a multi-pronged approach that really, I can't emphasize enough, that really depended upon the sort of the push or the motivation of higher administration, because it takes a lot of people and it takes a lot of money and a lot of effort to be able to do that, where a lot of the universities were simply closing their doors and going home or just going online. Our university made the decision that we would actually try to stay as true to a normal university as possible, and through federal funding, for mitigation and for testing, we were able to do that in a much better extent than many of our fellow universities, both here and elsewhere, were able to do.
It was an amazing feat, really, and to be you know, it's something that needs to be emulated globally, in my opinion. That's why I'm featuring your whole experience on this podcast. So you've really told the whole story, but I'm going to go through, I'm going to go through a series of questions that kind of
Sure.
expand on what you've said. So, so basically, you and your colleagues devised a timeline for the University of Arizona to get back to full in-person learning. Can you please describe this to the audience?
So the idea was, um, when your infection rates were high, up in the 10, 11%, obviously everything is closed down other than the essentials, like the testing laboratories. And what you want to be able to do is as people come to campus, and it was requirement, if you want to come on to campus for any purpose, whether it was research, classrooms, work, whatever, you had to be tested. And then you had to be follow-up tested through the course of the year. And so the idea was, if we could, find the infected individuals at first glance when they came on, we could isolate them and provide them with all the necessary things they needed, like, internet access, meals, that sort of thing, until they recovered. And we needed to be able to do that fairly rapidly. And so that was where the rapid test came in, that we could set up a testing venue over in our student union where we could handle thousands of people a day. Some of them would get PCR just to give us an idea of the prevalence, but the rest would get rapid antigen tests to look for a mitigation strategy. And what our results, our papers had shown, was that PCR was great for detecting the virus, but it's not great for telling you who's at risk of infecting others because it's so sensitive. So we were using PCR as sort of a prevalence strategy. Where is it, or where has it been? What should we be looking for? And that goes with the wastewater testing as well. And we used the rapid antigen test because we and others had shown that it doesn't pick up everybody who's positive, but it picks up the ones who are contagious. And that's what we were concerned about, is to isolate those who are contagious and then let them recover. And once they recover, they'll still be positive by PCR, which is a problem because they're no longer have active virus. And that's where the antigen test came in. So, we just looked at it the other day, probably during that time period, well over 300,000 tests. And so when you think, every one of those tests costs $23, that's a tremendous investment to be able to keep the university open by the university, as well as, not even counting the personnel costs that are involved. So we made that decision that if we could keep them as uninfected as possible, and that worked out pretty well, or at least find them pretty quickly, we could see the infection rates come down. And that's what we saw over that year, was that the infection rates gradually got down to where they were below what you would find out in the community, which was still averaging in the 7-8% range, and we were well below 1%. So the education actually worked because they were still out living in the community. There still was no vaccine at the time, or antivirals, but I think they had taken it to heart, that if you do something stupid, and people will, you will get infected. We will catch you when you come on campus, and you'll no longer be able to go to class or go to the lab or do the other things, that you're paying to do as a college student. So I think that was sort of the stick and the carrot thing, that, we expect you to act like adults, but if you don't, then we will catch you during the testing.
Yeah, I mean, the whole program was ingenious, frankly. Uh, it's something, as I've said, I'm repeating myself, that needs to be emulated. So yes, there were costs, but the costs of the costs of implementing the strategy were far below the costs of loss, and I think that's what people struggle with getting their head around. You have to pay for things like testing, air filtration, ventilation, whatever, in order to stay open, so that in the long run you don't economically lose, and also so that you keep your population safe. So you've really shown here a true proof of concept.
Well, I think, when we looked at this early on before implementing, we were expecting the university that year would lose somewhere upwards of 40 to 60 million dollars. And it turned out at the end of the year with doing this type of strategy, we still lost money, but it was less than 10 million.
Wow.
Now we're talking, it's kind of like monopoly money. Oh, it's only 10 million, but so I mean, it really did cut, our expected losses. We still lost, but not as much as if we'd done nothing. And more importantly, it sort of showed the students and the staff and the faculty that the university was concerned about their health, was making every effort, and so people were more willing to come back. Because then people get to the point where they go, well, if I'm doing everything online, why pay all the money to do that? Why not go somewhere else? But here they could actually start to come back, and the classes would open up in small numbers. First essential laboratories, then small classes, where you had 25 or 30, then you would have classes of 50, to the point finally you get to full size classes where there's no restrictions. But it was phased in, and there were metrics that had to be met. And if you didn't meet the metrics, you could go backwards or forwards depending on what the results were.
So how did you get the university staff and students on board with your plans? Could you tell us about things like the dashboard of testing results?
Well, the dashboard is sort of the community facing, the public facing website to be able to show what's going on at the university, what the infection rates are, because parents are concerned about their kids as well as the students themselves are concerned. And then you have the interaction with the state officials, the governor, the public health, that sort of thing. So the dashboard is more or less set up to show them what's going on a day-to-day, real-time basis. Are we having a surge like out in the community, or are we doing well? So that was good PR. That worked very well. People went to that. We held press conferences with the president every day, during the high part of this, so that he would answer questions with the media and with the government. That we did a lot of outreach to the students over that summer to say, we're going to open back up. This is how we're going to do it. This is how you're going to do, the testing, etc. And if you want to, we can't make you. But if you want to live in the dorm, if you want to come back on campus, you want to see your friends again, these are the things that you're going to have to do. And, if you get infected, we've got a dorm over here that we'll move you into for the next 10 days, provide you with your internet, provide you with your meals, everything you would if you were in your own dorm. And when you recover and test out, you can go back, knowing that, you're actually have some immunity and you should be okay. So again, it's sort of a stick and carrot that, here, do you want to come back? Here's how we're going to do it. And then the most important thing was the dashboard would show that it was working. So I think that's key. I mean, you don't want to be draconian about it and then have it not work. It actually showed that, with these sort of reasonable interventions on a day-to-day basis, you could actually see that the case rate was going down, hospitalizations were going down, deaths were going down, and people didn't start to believe it.
So you basically showed openness and honesty, and that's how you got people on board participating, and you educated them.
A lot of outreach. I think obviously, this is a community that's always very open. The university community, people talk a lot. They want to be, broadcast their findings or results. So if you tried to hide it, it was not going to work. So, and particularly, the people who work for me and for some of the other places, things were going badly. That meant we were at risk of getting sick and or having bad outcomes. So we definitely weren't going to hide it. If things were going south, we'd know it very quickly, and we would say, hey, let's close up shop, and maybe we do have to, to sit it out for a while. Luckily, that never happened.
Good. So the next stage of your program, you touched on this, was a decision of who to test and when. So different groups of students pose different risks of infection to themselves and others dependent on their activities. Can you please share how you identified groups to be tested and the frequency of testing?
It goes back to our first proof of concept with the athletic teams. We had the football team, which had, a couple hundred people on it. and we broke those up into small pods. We had seen what had gone on at the University of Alabama, where all their players would congregate together to do their weightlifting, their training, that sort of thing. And when one ended up getting sick, they infected 50 or 60 others. And so then everything shut down. So we broke them up into small manageable groups of 10, and they stayed with their pod of 10 as we followed them through the summer and did testing, almost every day for these people. So we could show that, if you would test in the groups, you could quickly find, who was going to be positive or who was going to be a problem. And that was sort of the approach that we took, was that high congregate settings like dormitories or like the cafeteria, those are your highest risk places. And so you have to go in and test everybody, and you have to test them every other day. For those who lived off campus, after we initially did the screening, they only generally were seeing 2 or 3 other people, whether it was their girlfriend or their spouse or, their roommates. There you could test them about once a week. And if you had 3 or 4 people and they would test on different days, you could sort of cover the entire apartment by doing that kind of testing. And then you could back this up by doing random PCR testing out in the community to see if there are any hotspots. And then you could do the wastewater testing, because if somebody in the building was infected, it would show up in the wastewater that's highly sensitive. And so you could, again, use a sort of a preview. And this was always, the goal was to know what was going on before it got to the hospitals. Because the hospitalization rate was somewhere around 2 weeks behind the infection rate, and then the deaths were another 10 days or so behind that. So if you merely were tracking hospitalizations or admissions, you were really behind the curve and trying to get a handle on how to mitigate this course of the disease.
Ingenious. Your whole method of organization and approach to this was truly excellent. Could you also talk about the importance of turnaround time with relation to the time you would aim to deliver a result in this population?
Well, that
So,
was the key thing, was that if you tell the kids when they come back to class and before they come to move into the dormitory, we're going to test you, you have to be negative. You can't tell them, but you're going to have to wait somewhere for 2 or 3 days till we get the results. So not only is that unfair, but it's impossible with 18 to 20-year-old people. And so that's where the rapid test comes in, if you can scale it up, where you can do thousands of tests a day. So each of our dormitories holds somewhere between 2,000 and 5,000 kids. So we could bring the entire dorm in on a Monday, test them all, get the results back. If we staggered them, each of them would have results back within the hour, and so they would know. And so when they would test with our approach, if there was a positive result, it notified the students so that they and their parents knew that they were infected. It notified campus health so they could immediately go and isolate and then see if they needed to have some sort of health care. And it notified the university to know, don't let them in the dorm room. Don't let them in a congregate setting because they're infected, or vice versa. Everything's all clear, it's ready to go. So that was sort of the key thing there, so that we could bring in about 3,000 a day, and through the course of an 8-hour day, we could test all those and get everybody's results back to them within an hour, which allowed them to stagger, come in and be tested, immediately go into the dormitories.
Yeah, it's fantastic because I read somewhere in your literature that with the student population, you could have one person who came into contact with up to 200 people within a 24-hour period. So you had this kind of mantra, didn't you, that 24 hours to deliver a result to a student population is too late. It needed
Yes.
to be delivered sooner.
Well, and that's, when we looked at this, and again, it's all done in a de-identified fashion so that, we can track a cell phone, but we don't know who the phone belongs to. You would find that there are, in reality, social butterflies. The majority of people on campus, come into contact with 5 or 6 people a day. But then there are others who come into contact with hundreds a day. Those are the social butterflies. And those are the ones you're really worried about, because if one of them is positive, they could essentially infect. And we saw that from our own experience that um, one of my technicians, I had a family member pass away due to something else. And so they went to the funeral. This was during 2020, and one of his relatives was not feeling well, but didn't want to miss the funeral and came, and she infected 23 others. She
Gosh.
was positive and resulted in deaths as well. So in a congregate setting with somebody who's hot, it's not just two or three, like you said, with an R0 of two or three. I mean, you go around and you hug and kiss, the people at the event. You could easily get, a super spreader event. So we were concerned about those individuals who are those social butterflies. But you're also concerned that, if one person gets five or six others, they get five or six others, and the window between getting exposed and showing up as infected is probably 3 days. And so that's where we sort of made the decision to stagger the repeat testing to make sure if we missed it on day one, we'd catch it again by day 4 if they were truly infected.
And back then, as we've said, the R naught was 2 to 3, and with Omicron, we're looking at an R naught of 8 to 15. You can see how quickly and why it spreads, so devastatingly across the planet, really.
Yeah, and part of that also is the fact that um, the uptake on the vaccination was less than hoped for or expected based on the demand for it when it was being developed. And the more unvaccinated people you have, the more likely you are to develop variants. Because I think if more people had vaccinated, you wouldn't have Omicron, or if Omicron had happened before the original one, the Wuhan strain, this sort of mitigation effort would have been more successful. Now people are so pandemic fatigued, they really are not concerned. They see that it's not anymore. It may in fact be less virulent than the original strain. And so they've more or less, if you haven't been vaccinated, they've given up, the sort of the fight.
Mm. Okay, that's another debate that we'll have at another time.
Yeah.
So exploring what you did. So what incentives, I mean, that's a good point actually to bring in this question. What incentives did you build into the strategy to encourage people to keep getting tested when they need to? How did you overcome pandemic fatigue?
Well, I mean, early on in the testing phase, that first year, there wasn't fatigue. There was a story in the paper every day or on the news every day about people dying, and we saw lots and lots of them dying in the ICU. And so people were very concerned. They were very afraid. They weren't necessarily going to get vaccinated, but there wasn't the fatigue, the fighting against wearing masks and that sort of thing. Again, what you're fighting against with the younger population is the short-sightedness of I'm negative today, that means I'll be okay tomorrow. And you try to get them to say, this is just a point in time. Tomorrow may be different, or 2 days from now may be different. But if you're living in a dorm, you had no choice. If you didn't get tested, every couple of days, you could get expelled from the dorm and you would lose your money, and you weren't getting your money back if you didn't follow the rules. If you wanted to be in a lab or on campus, you had to do the testing. What it was you wanted to have those who only occasionally came on, maybe once every couple of weeks, who are doing most of their learning from home. You wanted to get them tested, and that's where these sort of motivation strategies of bookstore discounts, tickets to the basketball games. There was a few grand raffles where you would get a tuition for the semester free, that sort of thing, and a raffle to try to keep people going. And during that first year, that worked very well. I think between the fear and the motivational strategies, it wasn't a big deal. It's only as it gets into the second year, and you notice that people don't want to. Some people don't want to get vaccinated, and they don't want to make efforts to protect themselves, that they become concerned. So
Right. Interestingly, for your PCR test, you used a saliva direct protocol with the saline gargle from British Columbia in
Right.
Canada, which you found more accurate and faster than a conventional nasopharyngeal PCR test, another proof of concept. We interviewed Dr. Anne Wiley last week about the evolution of this protocol. Are you able to tell us about your experience with this?
So one of our investigators, researchers, Michael Warby here, comes from British Columbia, and so he knows all the people up in British Columbia and has worked with them. And so the idea was, so what we did when we were doing proof of concept and we were comparing antigen tests with PCR tests, it was all NP swabs. We tried to do throat swabs, we tried to do nasal swabs, we tried to do cheek, just to do anything other than NP because people hate to do NP swabs. It's just uncomfortable. And it's also dangerous to the individuals who are making the collection. So we taught thousands of people how to do their own NP swabs. And, so that I said, I don't know how long your nasal cavity is. So if I just stick that back in there, I may injure you. You can slide it back. It won't feel bad, but it'll feel better than if I did it for you. But then, the publication of the Swish gargle, saline gargle came out. Michael Warby brought it back to us. We evaluated it compared to NP. Turned out to be just as sensitive, if not a little bit more. I think it depends on what day in the infection you do that. And so people were very compliant with that. To swish a little saline around in their mouth and spit it into a tube. It was very easy to implement that. And so that really helped in terms of the PCR testing. People didn't try to cheat on the test. They didn't try to skip their test. They were quite happy to come in and swish a little saline around in their mouth and get the test results. Yeah.
And you combine that with the saliva direct protocol because in BC we still use the traditional RT-PCR, but
Right.
you combine that with the new protocol that Anne Wiley developed, so you have the best of both worlds, that speed and accuracy.
Right, and we had to validate all of that, and again, when you're doing those things up front, they have to be validated. They have to be approved by, the CAP and the CDC to let you do that diagnostically. So it's not something that you can turn around and do overnight. But I think having this research community together, we would meet 3 times a week, to try to decide what's going on in a different university or state or a different country. What have you heard? So that we can start to look at some of these things very early on. And if something looks like it could be promising, we can start to validate it so that it doesn't take us 6 months to turn around, but maybe just, 3 or 4 weeks. And I think that was key. Yeah.
Again, that needs to happen in the real world, and that enabled you to have a much faster turnaround time with PCR, from what I saw reading
Oh
the
yeah, so it
literature.
cuts, a good 24 hours off of
Mm.
the time frame so that, since you don't have to go through and, and do the isolation of the message beforehand, but you can immediately go to do an amplification. It's tremendous. Yeah. You lose a little bit of sensitivity, maybe 1 or 2 cycles on the PCR, but that does seem to have impacted the biological significance of the assay.
Yeah, I still fail to understand why that isn't so much more widespread. Um, so there's a difference between being infected with SARS-CoV-2 and infected and contagious. You've touched on this,
Right.
that it's important to isolate a contagious person as they can spread the virus to others. An infected person who is no longer contagious will not spread the virus. PCR tests are notorious for giving positive results for weeks after a person is no longer contagious. Could you please explain to the audience what a CT value is and how you use these values alongside rapid antigen tests to identify contagious people and isolate them?
So CT values are the way that you determine how much virus is present when you do a PCR test. So cycle time. So do you have to go through the assay, 10 times, 20 times, 30 times before you can detect the virus? And obviously, the easier or the sooner you can detect it, the more virus there is. So a CT value of 30 means there's very little virus, but a CT value of 10 means there's a whole lot of virus. Complementary to that, we also get similar values on the antigen test so that we can determine how much virus is present when you do the rapid test. So what we were concerned with, and it came from our proof of concept, was that we had we had a couple of people during the athletics contesting who tested positive week after week after week for months. And so only by PCR, because if we tested them with nasal swabs or NP swabs, but it was with PC swabs, like or with the NP swabs and PCR, they kept testing positive. And surely, if you're positive for this virus 6 months, you should be dead. I mean, it's not that you continue to be virally infected. And so for whatever reason, it's an unusual RNA virus with an envelope that may hang around for a while, or there may be some cross-reactive proteins in your body that happen. But again, it's sort of pointed out that the PCR test is so sensitive that it's great for looking at prevalence testing, but it's not great for mitigation because then you're isolating people who aren't infected. Now, on the other side, with the antigen test, you may get a false negative, but if you test 2 days later, you'll find that person, they'll show up as positive. What you're concerned about is the false positive, that somebody tests positive, but they're actually negative. And then you isolate them in a big dorm full of real positive people, and then they might get sick. And so we put together a testing strategy that allowed us to identify the false positives by using a threshold of how positive you had to be on the antigen test to really be a positive. So we were able to eliminate false positives and use that as our strategy for looking at who was contagious. And then we could use the PCR for looking at where the virus has been and where we think it may be next.
So with CT values, I think you had a cutoff. If your CT value was below 30, then you were contagious.
Right.
And that would often correlate with the positivity of the antigen test, because they work they register positive when you're actually contagious. They won't
Right.
tell whether you've ever been infected. And then if your CT value was above 30 on PCR, then even if you kept testing positive on PCR, you would know that person's no longer contagious.
Right, and we looked at that in terms of trying to isolate live virus from these individuals. We could never get live virus to isolate or grow out of people with CT values above 30. That helped us to make that decision, because it's not something we make lightly, that you're infected but you're not, or contagious. That we could actually have real data to show if you had a CT above 30, you had been infected, you're now recovered or almost recovered, you're not a concern to the public, whether it's grandma if you see them at home, or your roommate in the dorm. But if you're under 30, then yes, we were concerned, and we wanted not only to pull you out of the community, but we actually want to put you in a place where we can watch you to see if you have a bad outcome. Because if you start to go south, we want to be able to intervene, and if we don't know who you are or where you're at, we can't do that.
Fantastic. What did you learn from the whole experience? Can you summarize the important points that you learned?
Well, I think collaboration of people who have multidisciplinary expertise really was sort of key to this. That actually has allowed us to set up what we call the Aegis Institute at the university, in expectation of the next pandemic. We expect either this one will continue somewhat, or there'll be another one. So, everybody has different expertise, and if you're able to bring them to collaborate and work together, you can do a lot of incredible things. The test, the treat, the trace is sort of key. It's not a cheap endeavor, but it really does make I think a significant difference by being able to do that sort of thing. So we think the testing obviously tells you who's infected or not, who might be contagious. The tracing to let you know who they might have been exposed to or exposed themselves to. so that we can now know who needs to be isolated and or treated. And I think that that's the other thing as well, is we want to make sure that we identify those who might have a bad outcome and try to take advantage of that early decision to be able to say, okay, we think we can help you through our approach.
So, where are you now? How did COVID vaccination change your approach to reducing the risk of infection on campus?
Well, we've done a lot of vaccination, and actually we've probably done now again over 300,000 vaccinations, because we are the biobank of the biorepository is also the place that receives, distributes, and tracks the vaccination um, in our community. So we're at the point now where the university is back to 100%. No masking now is required, even indoors, because the infection rate is well below 0.5%. And part of that, and that's also true of the community. So if the community goes above, I want to say it goes above 0.5% or so, we would have to go back to masking indoors. But at present, both the university and the community have such low positivity rates, whether it's true infections or breakthrough infections, that we're no longer required, even in the community as well as on campus, to have masking. Some people do, and I'm sure some people will continue to do that for a long time. But we're continuously monitoring on campus, as well as wastewater, as well as in the community, just to try to be ahead of the curve if there is a surge coming. But at this point, after 2 years, either from caution, vaccination, or infection, we think probably 80% of the people have been exposed in one fashion or another. And that probably helps to explain why we can now get back to almost, what it was before pre-pandemic.
So what's the vaccination rate on COVID vaccination rate on campus at the University of Arizona?
Of the students, this is completely opposite of what I thought. The students is probably 85% or higher. Um, the people who I thought would be most at risk, which would tend to be, faculty and staff, it's probably 60%.
And what's the rate of vaccination in the wider community outside of the university?
It's about 60, 65%.
Okay, so are you still rapid testing and PCR testing?
Yeah, but just not at the numbers. So most of it is, if there is a surge or if there is an outbreak, we'll go in and specifically test those areas, like say the athletic teams, or it's volunteer testing. Somebody says, I was away for spring break, or I came back, from visiting, so-and-so, and my throat is sore today, I'll get a test before I go on the campus. But the mandatory testing is no longer required.
And another important question that I forgot to ask, was the testing always free for the students?
Oh, yes.
Right.
That's
And
where the university spent all that money, was for,
yeah,
the free testing, because again, if you had to pay to go through an NP swab, you probably wouldn't show up to do it. So we wanted to make it as, we had testing sites all over campus. Want to make it as easy to do it, as free to do it, as you'll get the results back rapidly. So it was an extremely convenient and easy process.
yes. And do you have any other mitigation methods in play? Do you have anything like air filtration,
Yep.
ventilation?
So all the air supplies going into the buildings is through HEPA filters. We have what's called a germ buster team that goes out. That's part of facilities. Anytime there's a positive infection in a building, a room, or a dorm, they go out and sanitize. There is a team of individuals who will then escort positive individuals over to the quarantine facility so nobody else is exposed. So there is quite a bit of thought in terms of how to make this work. Um, with such a large space, particularly once you're outside the classroom, it's extremely difficult to do much if people won't wear masks. And that's really where, the masking rate was extremely good in that first year and a half.
Well, in my opinion, I mean, you've created a fantastic infrastructure for reducing the risk of infection to this coronavirus, which is incredibly important because, up to a third of people can go on to develop long COVID or post-acute sequelae, which really results in organ damage. I mean, all the
Right.
research that's coming out now with even one infection. I mean, vaccination is thought to possibly reduce that risk by half, but that's just still huge numbers of people. So you've really put a whole infrastructure in place that is protecting people from chronic illness. In my opinion, your whole team should be running the pandemic.
Well, we have one of those recover grants to look at long COVID. So, I think we're supposed to look at 9,000, and I think overall they're looking at 100,000 or something. But um, we do think that vaccination definitely does decrease the risk of developing long COVID. But and that's sort of the emphasis, to tell people that you're young and healthy, you probably won't have a bad outcome. I've known a few who've had bad outcomes, um, but a bad outcome is something other than death. A bad outcome is, lose 20 IQ points or have a bad liver or have, cardiovascular problems. Those also are bad outcomes, particularly if you're a 20-year-old and you're going to spend the next 80 years with this problem. And that's been sort of a difficult sell to convince people that there are bad outcomes other than dying from the virus that you should be concerned about.
Yes, and I don't think it's been highlighted enough in the media. I think we need to have really long COVID, post-acute sequelae results rates posted, as well as hospitalization rates and death rates, so that people understand that this is something that can really do damage and they need to protect themselves from infection. I mean, that's the whole point of this series, to highlight cases like yours and the technology that's out there to keep people safe from chronic disease.
Yeah, I think with, after the first year or so of these NIH grants to look at the long COVID, we'll have a better idea of what the rate is for that. And it probably is going to depend on, a variety of patient demographics as well as viral loads and things like that. So it's, we've seen it reported anywhere from 3% to 30%. So there's other factors in there that we haven't identified yet, but I mean, there's still going to be enough people who get it that it's a problem. Otherwise, the NIH wouldn't be spending, almost $1 billion to look at this. So, again, people don't want to hear bad news anymore. So I understand, but we're going to have to develop, better outreach, or at least strategies that we can educate without scaring.
Yes, and you know what? I think what you've achieved is actually good news. You've proved that with the right infrastructure, incredibly intelligent and clever people, motivation, and actually caring, that you can get back to some form of near normal life safely. By putting all of those mitigation factors in place. I think that's what's really key about this whole experience.
Yeah, I agree, and I think again, I have to always give thanks to our upper administration, started with the president, that he was willing to to make that investment and spend those dollars and to put in the effort, and he was in on many of our weekly meetings, just to get this going. Yeah, I mean, it starts at the top and goes all the way down, to the students. So all of them have to be willing to do it.
Yes. So when you say president, you mean president of the university, don't you?
Yes, yeah.
Okay, I'm just going to share something very quickly with you because we're nearly running out of time. Because I'd like the audience to see this. So, so basically, this is the 360 solution to pandemic control, and you and I have talked about this before, that I think needs to be implemented globally. We won't get out of this pandemic by boosting our way out of it through vaccination. Vaccination is the most important mitigating tool that we have for COVID-19, but it's not the only one, and I think you've proved that. And you really now I would say you've done proof of concept of 90% of this. You had regulator support with your president, a testing strategy, wastewater monitoring, an infrastructure that you created. You provided support during isolation, contact tracing, education, and now the environmental mitigation with, the air filtration and ventilation that you've implemented, and you've pushed vaccination. So, it's incredibly commendable, what you've done.
I appreciate that. And luckily it worked. I mean, you can actually show that by doing all this, you can actually get back to almost normal. In fact, I would say by the fall, we'll be back to normal, unless something happens, but yeah.
Yeah, no, I would say it was not luck. I would say that it was high intelligence, care, and meticulous planning. And I just want to say, because I know we've reached the end of time, thank you, David, for you and all the team that your work have done, and for really showing us the way out of managing this pandemic by your wonderful and excellent example of COVID mitigation at the University of Arizona. It's been a pleasure and a privilege to interview you today.
Thank you very much for the invitation. Happy to do it.
And please join us next week for episode 9, SARS-CoV-2 is Airborne Part 1 with Professor Jose Luis Jimenez. Thanks for listening to this week's episode of COVID-19 The Answers. If you enjoyed the episode, please subscribe, rate and review, and do visit our website kajalamedical.com/COVID-19 The Answers.